Once again, hello everyone. Welcome to today's webinar on Social Vulnerability Index Utilization in Public Health. My name is Francis Agama, and I am based at the DSI Coordinating Center at the University of Cape Town. It is my pleasure to introduce to you our speaker for today's webinar. His name is Professor Lawal Olanrewaju. And he's an experienced geographic information science specialist with a background in biophysical and social sciences. He has experience in remote sensing and geocomputation. He has led the development of advanced tools and analysis for addressing complex social environmental issues. He has led and continues to lead and collaborate on multiple research projects, resulting in the creation of nationally relevant spatial models and data sets. His works in general leverages big data, artificial intelligence, and machine learning to extract insight from natural and social systems. With extensive experience in spatial data science development and geocomputational techniques, he is well equipped to contribute to innovative geospatial research. I think without further ado, I will hand over to our speaker, Professor Lawal. Over to you.
Thank you very much for the introduction. Good afternoon and good morning to everyone. It's a pleasure to be here today. And I will be talking about social vulnerability index utilization in public health. I am from the University of Port Harcourt. Let me do a quick check. I hope everybody can hear me very well. Francis, is the sound very clear?
Yes, it is.
That's very good. That's very good. So without further ado, let's get started. I will take you through the content. Francis, content. Next slide. So to cover the presentation today, there are three major areas I want to address. We'll do a quick background to get you familiar with the context of what I'll be talking about. So for that, I will introduce you to the objective of the webinar. What are the areas I'm going to be covering? Then I'll move on to talk about social vulnerability itself. And then we'll talk about how has it been measured in the form of the social vulnerability index. Then we'll look at the origin of this index and then some of the examples of structures that people have used or the method that people have used to construct it. Then we'll move on to the second aspect where I will be talking about examples from different parts of the world of how SVI has been used in public health. And we'll run that off by looking at the limitations and then look at what is in the, or what are the things on the horizon in terms of development of SVI and in terms of the utilization of SVI. So let's set the stage and get started with the introduction. So for the introduction, you can move to the next slide, please. For the introduction, the objective for this is that at the end of this presentation, you should have an understanding of what social vulnerability is and the index itself, what ways have people, what method, what ideas have people used in constructing it or representing social vulnerability. Then we'll move on to give you an exploration of the different applications of SVI in specific cases of public health. And then I will finish it up by looking at the limitations and future direction for research and development of social vulnerability index. So next. The best way to kind of understand where we are coming from when we talk about social vulnerability index is to think of hazards. Hazards are omnipresent in our daily life. They are always there, but what we do as human beings within the environment is what determines whether the hazard will turn to a disaster. So hazards are precursors of disaster. So in order to manage disaster, and manage our environment, our existence on this planet better so that we can minimize losses of life, property, financial losses, we need to understand hazard, we need to understand risk that we're exposed to, and we need to understand what are the vulnerabilities as well as the resources that are available to manage these hazardous events or disaster that may occur. So this now brings us to talking about vulnerability, because we know that we need to understand risk, we need to understand hazard, we need to understand vulnerability, and we need to understand the resources that are available to manage disaster and other emergencies. How has vulnerability been conceptualized and as well been measured or operationalized? Some definitions are in order. We could look at vulnerability as the susceptibility of a population, a community, group of people to harm and their capacity to cope or recover when such harm occurs. Another definition or another conceptualization of vulnerability is the potential for loss, either to loss of life or financial loss due to a disaster or hazard in an environment. So that's to do with the susceptibility of people to certain losses or harm and their ability to actually cope or recover when such occurs. So with these, it is clear that people and places can be vulnerable, and that vulnerability could be at two different levels. It could be as a result of the environment in which they are living, or it could be as a result of the settings, the arrangement of the structure within the society would make them vulnerable. So therefore, we are talking of vulnerability at two different levels: biophysical vulnerability or social vulnerability, which is the purpose, the central theme of what we'll be talking about today. So biophysical vulnerability has to do with the attributes of the event or the physical condition which influences the outcome of the harm occurring within a particular environment. So biophysical, remember, has to do with the geographical context of where people are that could make them vulnerable to losses and damages. So now we can move on to now talking about social vulnerability. Next slide, please. Francis. Oh, thank you very much. So social vulnerability, also the same way there are different conceptualization of it. Social vulnerability has to do with the attribute of the society which could negatively impact the outcome of the disaster or hazard event. So in essence, what are the characteristics of the society that could make people vulnerable or will make the outcome of the already dire situation in case of hazard or disaster that could even exacerbate the negative outcome? That is what we refer to as social vulnerability. Another definition or another conceptualization of it is the characteristics of person or community that could affect their capacity to anticipate, confront, repair, or recover from the effect of a disaster. So when we look at these two, it still boils down to something that has to do with the way the society is constructed. So we can now look at social vulnerability in a little bit more detail, which means anything, social vulnerability itself, it can hinder the ability to respond, the ability to look at the signs, to take notice of the signs and of the warnings that are coming. And then it can also hinder the ability to cope with the consequences. So which means not only does the impact of social vulnerability can be seen before the hazard event or emergency, it can also impact during the hazard event or the disaster and even after the event. And there are many things, there are many factors, and many. So it means that there are so many factors within the social fabric that could hinder this. Some of them include social inequalities, poverty, access to job, transportation, and so on. So all these are manifestations within the society of how people live, how they interact, how they exchange goods and services, how they have access to facility. All these have to do with the social fabric. So which means social vulnerability is tied to the way people live, their experience within the community, their experience of hazard, their ability to respond, to cope, to recover. All these are predicated upon where they live, the economic activities they are engaged in, the economic activity of the society, the demographic attribute of the society. So essentially, the pre-existing condition within the society can significantly influence the capacity of the people to respond, to cope, and to act when there's an impending disaster or during the disaster or at the aftermath of the disaster. Next slide, please. So now that we understand what we are, when we say social vulnerability, we have an idea of what we mean by that. Then let's now look at how do we measure it? So when we say measuring, we're talking about the social vulnerability index. Okay, so if we look at social vulnerability index, we have, at least for now, we have a good understanding of what we mean by social vulnerability. Then to define the index, Cotter in 1996 defined it as a measure to quantify social vulnerability of different communities to natural hazard using social vulnerability indicators. So another definition from Flanagan, 2011, they define it as a measure that uses social variables to estimate the vulnerability of community to natural and human-made disaster. I and my colleague would define it in 2015 and 2021 as a quantitative description of the relative vulnerability of a place based on socioeconomic variables. CDC has also their definition, but one common thing about all these definitions is that there is an agreement that it's a quantitative approach to understanding or describing the social vulnerability of place or people. Okay, so finally, Allen 2021 defined it as a composite indicator reflecting several dimensions to identify the most socially vulnerable communities in a particular environment. So these are some of the examples of, okay, I'll do that. So what are the origins of social vulnerability? I hope that is a little bit better. Can you guys hear me a little bit better?
Yes, we can.
Okay, that's good. So social vulnerability has its origins to the works of Cotter in 1996, Susan Cotter from the United States. She developed proposed the vulnerability hazard of place model. In this model, the manifestation, the understanding is that in any environment, there are always hazards, which we are all exposed to. And there are two dimensions to that exposure. There is the biophysical part of it, which has to do with the geographical context in which we live. And then there is also the social fabric aspect, which is the societal part of the vulnerability. So these give birth to what we refer to as the biophysical vulnerability and the social vulnerability from this model. So biophysical has to do with the geographical context in which people exist. And then the social fabric aspect has to do with the social vulnerability, which is the social context in which people live. When we combine the two, it gives us an indication of the place vulnerability, because a location is just a location. Without people, location becomes a place. So when we combine the environment, the biophysical vulnerability, and the social vulnerability, we get what we call the place vulnerability. So this model gave birth to what we now, everybody is now talking about, which is the social vulnerability index, and it captured that societal context of vulnerability. Next slide, please. So the initial development for SVI was targeted at helping in the management of disaster. So it was targeted at disaster risk management, so that disaster risk management officers or managers can know where do they need to deploy resources and so on, where are the most vulnerable people and things like that. But in recent time, we have seen significant growth in the application of SVI, Social Vulnerability Index, in public health to help to understand health disparity and also address the problem of health disparity. So building upon the work of Susan Cotter in 1996, the Center for Disease Control in the United States, they developed their own SVI, which they targeted for the use of by public health officers and other people in public health and also in disaster risk management. And they developed that to, at the census tract level, to, and in their development, they follow the steps of all the dimensions identified by Susan Cotter. So there are 4 dimensions within the social vulnerability index developed by the CDC: the socioeconomic status, the household composition and disability, the minority status and language, as well as the household housing type and transportation. So they follow up on what Susan Cotter developed in 1996 and used the same structure. So what do we mean? So in terms of this structure, the American perspective is quite common. We can see that across many examples of social vulnerability index globally. So I decided to call the American perspective because we have also seen the development of SVI that are context specific and at times hazard specific. So the initial one, which is the American focused development, I call it the American perspective. It has the 4 dimensions or the 4 themes that I've highlighted earlier. That is the socioeconomic status that covers the factors like poverty, unemployment, income, education, and so on. And then we have the household composition aspect or theme, which includes consideration like the age, especially those who are under 18 and those who are over 65, as well as disability status and so on. Then we have the minority status, which is expected to cover in case of people who are systemic disadvantaged or systemically disadvantaged as a result of maybe language barrier, and also race and ethnicity may make them disadvantaged. So in order to capture that, that's why we have the minority status and the language aspect. Then we have the housing type and transportation, because the kind of housing that you live in could also give an indication of how you are in the society. What is the your status within the society? So housing type, transportation, which could also impact on your access to some economic infrastructure. So that was captured in the housing type and transportation. So these four themes were put together, and they have 15 variables extracted from the US Census Tract to compile them. So this is the American perspective in terms of structure of constructing the SVI. And the SVI is calculated using the percentile, so which means the higher your value, the value for the SVI, the higher your vulnerability. And it was calculated in such a way that comparison the tracts, the census tract are ranked within the set, and then so that when you look at where you are, you can compare yourself, a particular census tract, to census tract within the state, and you can also do that at the national level. So individual variables were also used, like the 15 variables, they belong to each theme. And for each theme, scores were also computed before the overall SVI is computed. So we have that. And so which means for each of the four themes, their scores. So you can see where each census tract is in terms of ranking for each of the themes. And then you can see the overall ranking for the combined SVI scores. So we have other countries and other people also developing the SVI, and other people across different parts of the world outside North America, they have used different structure looking at what is available. For example, the work I did with some of my colleagues, we looked at, we used primary school enrollment or attendance, and primary school, secondary school attendance, literacy rate, age structure, population density, road density, car ownership, and so on, to develop a social vulnerability index. And we took into cognizance the challenges of getting analogous data set of variables that are comparable to what we have in the United States. So we have to look at what are the other things that are, what are the other factors that are peculiar to where we are in Nigeria that could influence or affect our social vulnerability. So we developed that in line with what is available here and what the context of the society in terms of vulnerability is. So that's an adaptation of what we have in the United States. And next slide, please. Okay, so we have another approach that was developed in New Zealand. These are just some examples because there are so many variations from different parts of the world that people have developed something that are context specific, that are peculiar. They develop index that are peculiar to their own environment. So in New Zealand, Moore et al. In 2021, they proposed a new approach in which they develop the social vulnerability index that uses 10 dimensions. So instead of the 4 dimensions proposed by the Susan Cotter and the CDC, they proposed 10 dimensions, and for each of the dimensions, they have key indicators that were identified, and data were collated for it and used to construct the social vulnerability index. So the message here is that different people, different part of the world, people are developing things that they believe the index in the best way they think represent their society in terms of vulnerability. Next slide, please. Then we have another development from Kenya, which they constructed their SVI, and the work was done by Macharia, Joseph, and Okiro in 2020. They developed 3 different indices, and one of them was SVI. And for their own SVI, they used 3 subdomains. So 3 then they have the population characteristics, and then they have access to services. So these are the three dimensions which they focused on in developing their own social vulnerability index. So they developed something that they believe is much better for the environment in which they are living. So if we look at the examples I've given so far and the definitions where we started from, it is clear that SVI is a multidimensional index, and it provides a more holistic measure of vulnerability, which is better than if we are to rely on a single factor like some before. It used to be that we use income, or we use ethnicity, we use maybe access to job, access to roads and things like that. It used to be like that, but now we have a multidimensional index that can capture better. It's not a perfect index, don't get me wrong, but it captures the multi-dimension of social vulnerability in, in the context of managing emergencies and disasters. And the good thing also is that it is an adaptable index that people can develop it the way they feel that it's more suitable to the environment in which they find themselves. And it can be developed also based on the data that is available. Next slide, please. So before we get on to discussing this example, Francis, please, I will ask for just a minute or two to try and sort out something so that I can move on to a computer instead of presenting from my phone.
Sure, that's fine. So I think we will give Professor Lawal a break while he tries to sort out things, but then please put in the chat any question that you have with regards to the first part of the presentation. So the first part of the presentation has given an overview of what SVI is, and he has also given an example of the various indices that are implemented in different countries. He has also highlighted what is being implemented in Nigeria. So please feel free to put in the chat any question that you have, and then he will address it. Anyone with a question, the question can be put in the chat. Please feel free to put in the chat your question. If you want to voice your question, then you would have to use the Zoom functionality to raise up your hand, then I can give you access to talk. Okay, so we have a question from Red One. Yeah, so are we going to have access to the slide? Yes, the presentation slides will be made available. The recording will also be made available. So the recording will be hosted on the DS Africa YouTube channel. The slides will also be made available to you all. We will just put together a short webinar feedback survey. So once you complete the feedback survey, you will have the slides included. So yes, it will be made available. Any other question? Maybe while we continue to wait, I have a question to the audience. So how many of you are working on project or public health project that leverages social vulnerability indexes? Please, you can either give me a thumbs up or just put in the chat. I work on something like that. That will be helpful. So how many of us are working on public health projects that leverages social vulnerability indexes? Please put in the chat. Okay. We have one question, but then please put in the chat if you are working on social vulnerability indexes in the public health domain. Laura, just let me know once you are back, and I'll hand over to you too.
Okay, well, a few more minutes, please.
Sure. I'll continue to gather questions. Any other questions? So we have one question from Wole Oyedele, and yeah, more questions with regards to the first part of the presentations. Please feel free to put your questions in the chat. If you want to voice your question, to just give me a thumbs up, and I will give you access to do so. And also, I would also want to have a sense of how many of us are working on projects that leverages the social vulnerability indexes. Repeating myself again, you can put your questions in the chat while we wait for Lawal to get back. And also, I would want to have a sense of this group, how many of us are working on projects that leverages the social vulnerability indexes that we have heard about in the first part of the presentations. Okay. Yes. Yes, could you speak up a bit? We struggling to hear.
If Dr. Olawa is back online, it will continue from there.
He is back online. Okay, great. So Lawal, we have one question. I'm not sure whether you take it before you continue. The question is, considering different SVI domain definitions and references, what will you describe as the best appropriate SVI composite? And the question is from Wole Oyedele.
I don't think there is one particular best composite. It has to be that you look at the circumstances. For example, we'll get to that part when we talk about some of the recommendations I'm going to make later, that we have to move away from designing one size fits all to designing SVI that are context specific or even hazard specific. So I cannot tell you that for Kenya, you must design your SVI this way, and that's the perfect way. You will have to look at the circumstances, because, for example, something that might make you socially vulnerable in Nigeria may not make you socially vulnerable in Kenya or in Uganda. There are some basic things that we can consider to make people socially vulnerable, but it doesn't mean that it's general across all countries. And it might even vary from state to state. And I'm going to reveal that in subsequent slides to see how things can vary when you move from condition, from state to state, from geographic area to a different geographic area. It can vary. So there's no one size fits all.
Okay, thanks, Lawa, for your response. I have a follow-up question, if you don't mind, before you continue. So okay. Then, how do you get to compare the measures given them, for example, different populations? For example, if there's a for example, COVID-19, for example, it affected multiple countries, different populations. So how do you, leveraging on the SVIs, how do you get to compare the impact if the measures or the indices vary depending on specific scenarios?
Okay, good question. Now, one of the things we have to take into cognizance also is that if I develop SVI for Nigeria, and we have this as part of the Inform Africa project, we're developing a social vulnerability index for 10 different sub-Saharan Africa. It is difficult to
Lawal, you've dropped. We are no longer hearing you. I think we just lost Lawal. He will try to rejoin.
of their So going back to what I was saying, it's difficult for you to compare them directly, but what we can generally do, you have to remember that what we are talking about is relative. Okay, so if I rank places within Uganda, if I rank them on a scale of let's say very low vulnerability, moderate vulnerability, high vulnerability, very high vulnerability. If I have something like that, those classification, I can look at the proportion, I can look at
Sorry, Lawal, are you there?
Yes, we're back. We're having some network connection issue. So we can do comparison on a relative basis in terms of knowing how many special units belong to this particular class, but it's not possible for us to be saying that, oh, this region is poorer than this or that. What we can do is relative comparison in terms of proportion of areas very highly vulnerable, moderately vulnerable, and things like that. So we have to be careful when you use this kind of multidimensional indices. It is not directly possible for you to do this kind of comparison because there are so many nuances in terms of what makes people.
Okay. I think once Lawal rejoins, we will move ahead with the next section of the presentation. But then in the meantime, please use the chat functionality to put any question that you have, and he will address it before the end. Yes, Adiola, do you have a question?
Okay, I'm switching to another computer now. I hope you guys can hear me.
Yeah, we can.
So can you guys hear me?
Yeah, we can. So let's move ahead to the next section of the presentation.
Okay, you are...
Because I was in this present.
If you are not host,
Okay.
also they might mute you.
Yes,
Hello.
Lawal, we can hear you. We can hear you.
Okay. Okay. Great.
Okay, great.
Yes, we can hear you.
Such comparison might be difficult, but country comparison can be made. But once you go outside that country, it's. I mean, in terms of practicality, I don't think it's of any use for you to be comparing places.
Okay. It seems that Lawal is having a technical glitch. he will try to resolve as soon as possible. Then we continue with the next section of the webinar. But in the meantime, just put in the chat any question that you have, and it will be addressed at the end of the talk. While we continue to wait for Lawal to rejoin, please feel free to put your question in the chat. So far on the first part of the presentation, if you have any question with regards to the SVI and the examples that he gave from the various countries, please feel free to put in the chat. Once he's
I'm back.
Great. Okay, so now we can move on.
Okay, so next slide. So we're going to get to look at specific examples, because I believe with that we can, some of the questions, more questions will come up, but at least we'll get some perspective on how people have been using SVI across the public health sector. So since 2000, the work of Painter in 2024 shows that there's been a significant increase in the use or in works or articles talking about SVI globally. And you can see from the chart, it's obvious that since year 2000, 2020 rather, there's also been a significant increase in the number of works talking about SVI. And I think the trend will likely continue, because as people begin to understand how to develop it better and how to develop something that is context specific, then the use, and also as people begin to understand the benefit of using it, I'm sure we'll have more development in that area. So that is where we are. And then we're going to, let's look specifically at what people have been doing in terms of public health and the utilization of SVI in public health. We have seen where they've been used to predict and understand variation in health outcomes across different communities. We have seen how it has been used to identify disparity in health disparity across communities, understanding the impact of social factors on disease outbreak, planning of interventions. We've seen other places use it to find linkage between social vulnerability and chronic diseases, so that they can use that to address some aspect of social vulnerability that are directly linked to the chronic disease. And we have also seen it being used to address inequity in access to services, and also focus on addressing effectiveness of health interventions. So these are broad areas where I've seen applications. So I'm going to move on now to talk about some specific examples of how people have used SVI in public health. So let's look at the example for COVID-19, because that is still in our memory. We can see COVID-19, extensive use of SVI in COVID-19. I start with since we started from the US perspective, let me start also from the US perspective, where we see the CDC develop also the Minority Health Social Vulnerability Index. And instead of the 4 themes, they added 2 additional themes to that, so that we have 6 themes in that particular index. So they used the number 4 themes from the original Social Vulnerability Index, and their target was that by adding the 2 additional dimensions, they are able to target these for use by public health officials specifically, especially during the COVID-19 pandemic. So they added the health infrastructure dimension, and they also add the medical vulnerability dimension to the social vulnerability index that was developed by them. And they anticipate that this will help to support their responders and the different agencies at the state level, at the local level, at the national level, to focus on equitable distribution of testing and vaccines, and also to identify where do they need to put extra language assistance during their outreach efforts and services. They anticipated also that this will support planning and evaluation of efforts in terms of what are the intervention put in place, what are the testing facilities and resources put in place, how has that helped in curbing the spread and hotspots of COVID-19 across the United States. So it also, they anticipated to help in identifying the medically under-resourced communities and planning for community level efforts to address such systemic factors that could impact on health outcomes. So this was a very good example of how SVI has been used, especially during COVID-19. So moving on from this, we see the example of Frochen in 2024. They look at COVID-19 infection, mortality, and max mandates, and they compare that with social vulnerability index. So their focus was to look at whether infection and mortality decreased in areas that are most vulnerable based on the SVI, and they also to look at whether infection and mortality disparities varies across areas, different areas of vulnerability with respect to the length of the max mandate. So effectively, they want to see what are the effects of the max mandates in the United States based on how vulnerable the different society, the different communities are. So let's move on. So what was their observation? They observed that the duration of the max mandate is associated with both decrease in infection and mortality among the most vulnerable. So effectively, if the most vulnerable people were, if the max mandate is put in place, it actually worked in decreasing infection and mortality. So that provides an evidence that the max mandate was associated with decrease in infection and mortality. They also found out that the mortality, COVID-19 mortality in places that are more vulnerable with no max mandate, they have 1.57 times higher mortality than places that are low vulnerability and also have no max mandate. So effectively, their work shows that social vulnerability has a significant influence. At least it can be, we can see the association it has with mortality in the United States. So there is no arguments to say to support that we should not have such a thing in terms of a pandemic. So they also noticed that in places where there is full max mandate, even where we have full max mandate, the low vulnerability area and the high vulnerability area, there is still a marked difference in terms of mortality. So it shows that we cannot only look at the outcome, we have to look at the context in which the outcome came from. So social vulnerability is important when you are dealing with public health issues. So from their findings, we can see that max mandates were associated with decreasing cases and deaths. Max mandates were associated with narrowing the infection disparity. So between the low and the middle, low and mid vulnerability area, max mandates can narrow the disparity in terms of the infection disparity. So same also in terms of the mortality from the high and the mid vulnerability area, there is also the narrowing of that infection. So we can anticipate with SVI that if we have the SVI of places, if there is a pandemic, we can anticipate what is likely to be the impact of any intervention that we put in place. Then we move on to the example also from social vulnerability and COVID-19 in the United States, the work of Karaye and Oni in 2020. They look at the SVI and COVID-19 using data for COVID-19 data and SVI from CDC. So next slide, please. So the observation shows that there is a strong correlation between high SVI scores and COVID-19 cases. But one interesting thing that came out of their work is that it is the minority status and language component. Remember, I highlighted before that the USA operationalization of SVI uses 4 dimensions: the minority, the socioeconomic, housing, and transportation, and the minority status. So they found out that the minority status and language is the one that is particularly associated with COVID-19 cases. So the higher the score on that particular theme, the higher the COVID-19 cases. So one of the other things they observe is that there are local, there's spatial heterogeneity. It means that there are local variations that are not captured by the general national variation that you see. So this was also similar to the findings of Wong in 2022 that shows that SVI is not evenly contributing to the number of cases across the United States. So there are local dimensions in terms of explanation or relationship and association that differs from what you see at the general level. So in terms of looking at cases in the United States, it means that there are some specific local circumstances that could impact. So within the SVI index, some of the themes are better at explaining the outcome that we see than the others. Next slide, please. So looking also furthermore at the SVI and negative health outcomes for hospitalized COVID-19 patients, because all the other cases I've shown you are looking at the general population. Now, if we look also at hospitalized COVID-19 patients, the work of Islamet 2020 looked at that specifically, that is there any linkage between the county level social vulnerability and the negative outcomes for those who are already hospitalized. And from their study, they use data from people who are admitted already, and they compared it to the SVI from the county in which they live, their place of residence. Okay, so next slide, let's see. Next slide, please. Okay, I can see it, it's all right. So the observations reveal that there is a statistically significant association between higher SVI and increased odds of hospitalized death. So which means if you are already hospitalized and you come from a highly vulnerable county, you have a higher probability or higher odds of dying or having a major cardiovascular event if you are from a very vulnerable county. And this is an interesting thing. It means that even when we get people into the hospital, they are hospitalized, SVI, the SVI of their residents their resident county can also give us an idea that we may need to do more for them because of where they are coming from. Because we now know that where they're coming from also has an influence on what their health outcome, will be, even when they get to the medical facility where they are being taken care of. So we found out that their study revealed that independent of race or ethnicity, COVID-19 outcome can still be shaped by where you are coming from. So other example from Nigeria, where I and one of my colleagues, we developed a COVID-19 specific SVI. So that's also the context specific example I highlighted in the question that was asked earlier. So we developed these taking cognizance of factors that could make people vulnerable within the society to COVID-19. So move on to the next slide, please. So we found out that the higher the SVI, the higher the vulnerability, the higher the number of confirmed cases that were found across the state. So since the local government level data was not available, we have to aggregate to the state level. So mean SVI value for the local government, for the state, were found to be associated, positively correlated with number of confirmed cases, number of active cases, and number of deaths. So what we found out in essence is that the health outcome is a reflection also of the combination of predisposing and protective factors within the society. So the SVI that was designed was able to reveal that where people are coming from also can determine what the outcome will be at the state level. Then there are other examples from Peru, where SVI was developed specifically for COVID-19, the same outcome. Let's move on to the next slide. So they found out that this is one of the unique SVI development that I've read in recent time, and I deliberately brought this up because all the other works have shown that the higher the SVI, the higher the number of cases. This particular work from Peru bucked the trend, and it shows that the highly vulnerable places are not having the higher number of cases. They did not experience higher cases and higher mortality or rates for COVID-19. And this also brings about the issue I highlighted earlier, that there are always going to be context specific, there are always going to be peculiar cases that you need to take. There are things that are going to be peculiar with different environment that you have to take into cognizance. Why did we get a kind of contrary finding in Peru? The places that are highly vulnerable in Peru, they are around the mountainous area. They are close to the Andes mountain. So accessibility to those places are poor, access to healthcare facility, and so on. So also this isolation also made people less, it reduces their contact with people who might bring the diseases to them. So therefore, what made them vulnerable in terms of the social context also kind of protect them from getting in contact with somebody that could infect them with the disease. So this brings something to the fore that we always have to think about the context. Okay, so when you are developing SVI, you have to carefully look at the context of the environment when you are doing that. So this is an interesting piece of work, and I like to use this so that people can realize that there is no one size fits all. Then we have also vaccine uptake and SVI. This was done in Nevada, the United States, and they found that SVI was weakly and negatively correlated with both vaccination rates. They had two vaccination rates. They looked at people who took the first dose, and they look at, they computed also the proportion of people who took the two doses and the booster. So they called one complete, and then they called the other one incomplete. And they found out that SVI was weakly and negatively associated with both of the vaccination rate. But they found out that minority status and language is positively correlated with vaccination rates. So which means those counties that has a high score for minority status and language, they have a higher rate of vaccination, both for the complete and the incomplete. So this is an interesting dimension, which means those places that have higher vulnerability score in terms of minority status, they tend to have higher level of vaccination rate. So clearly showing that if you want to get more people to take the vaccination, you need to look at where are people more receptive to it and what can you do to make other people more receptive. So this is also an interesting piece of work, looking at how SVI can help you to understand what is going on. Then another, we can skip this. I've already talked about it. Then we have also the one from Tutulero et al. 2021, looking at COVID-19 cases and SVI. And the similar thing, they found that even after controlling for testing rates and stay-at-home measures, there is a relationship between social vulnerability and COVID-19 cases. Please move on to the next slide. That's where the explanation is. Next slide, please. So this is a very good map that kind of captures the bivariate association between cases and SVI. So they found a statistically significant positive association between SVI scores and COVID-19 incidences. And also, out of the 4 themes of the SVI, they found that the socioeconomic status and the minority status and language are strongly associated with COVID-19 scores. Because what this is saying is that the counties across the United States where you have a high score for minority status and socioeconomic status, higher scores, where there is higher vulnerability for these 2 dimensions, there are more cases, and maybe that could explain why we have a higher level of vaccine uptake as we saw in Nevada in the previous work that I showed for you. So it means that there is need for a targeted public health intervention to address this, because this is showing that the minority status and the socioeconomic status can help to tell you, to point you where you need to go within a state or within a community. So overall, we can see SVI was very useful in identification of people at risk, community at risk, monitoring equity in vaccine distribution. We can see where are vaccines going to where people are more receptive and where there are more infections. Okay, so this is important. Next slide, please. Then SVI was also useful during COVID-19 in targeting of resources and intervention. It was useful in assessing capabilities, and it was also used in evaluation of what worked and what didn't work. And we can use it to also, it was also beneficial in helping to assess the effectiveness of the different intervention. For example, when we look at the max mandate, we can see whether the max mandate actually narrowed the disparity in terms of mortality. We can see that SVI was able to show us whether the intervention actually worked. So that brings a close to talking about SVI and COVID-19. I have so many more examples, but I would not want to go through that. So let's now focus on disease disparity and other health outcomes. We'll talk about obesity, we'll talk about so many other ones. So let's get on to that. So the work of Tong in 2024, they look at SVI and the mortality among Medicare beneficiary and acute ischemic stroke. So they use data from Medicare fee for service beneficiaries who are aged 25 years and above, who are hospitalized with AIS. So, and they did this during the COVID-19 pandemic period. Next slide, please. So what did they find out? They found out that the beneficiary who have AIS, from living in the most vulnerable counties, they had higher mortality, regardless of their age, their sex, their race, and ethnicity. So coming from a particular place where there is high vulnerability already put you in a disadvantaged position. That is what they found. So irrespective of any other thing, irrespective of your age, your sex, your race, and your ethnicity, if you are coming from a vulnerable county, you are likely to have a very negative outcome if you have AIS. So that is what they found. So which means SVI is pointing us already to what the outcome is likely to be if we don't change something from within the society. So this is one of the things that was revealed by this work, that SVI can show you what is likely to happen even before it happens. At least it can predict, it can help you to anticipate, and also put resources in place to make sure that the negative outcome did not occur. Next slide, please. So there was another example from Ratna Pradeepa in 2017. They look at the trying to use SVI to predict Lyme disease incidence or occurrence in the United States. They look at county level SVI. They use annual Lyme disease reported cases from 2000 to 2014. And their findings are, next slide, please. They found out that SVI has a significant quadratic relationship with the Lyme disease incidence rates at the national level. However, they found that the model they constructed using SVI as a predictor, they found out that it worked better in certain regions. For example, the model performed fairly better in the mid-Atlantic zone of the northeastern region and South Atlantic zone of the southern region of the United States. So it means that this model may not work the same. It does not perform excellently across the entire United States. It works better as a predictor in certain places, and it didn't work very well in certain places. So which means once we look at the SVI, you can look at where it's working well and use it as a predictor, and where it's not working well, you look for other things that can help you to predict better. Next slide, please. So the issue of stillbirth was also looked at, stillbirth rates and social vulnerability. So Moore et al. In 2024, they examined the association between county-level stillbirth rate, environmental risk, and social vulnerability. So go on. Next slide. So they observed that there is a positive association between stillbirth rate and social vulnerability. And they found out that even though the overall social vulnerability index shows a positive association, there is a strong positive association between socioeconomic status theme and increased stillbirth rate. So the socioeconomic status is a better predictor for increased stillbirth rate than all the other three things within the social vulnerability index. Then they also found out that places that have high social vulnerability, they also have a preponderance of they have a high level of environmental risk factor for stillbirth. So which means there's an intersection between the biophysical vulnerability and social vulnerability in relation to stillbirth rates in the United States. So this finding has also been corroborated by the work of Marquez in 2021 and Silva in 2022. So looking at stillbirth rate, we can still see how social vulnerability was able to help us identify where places that the risk is unusually high for stillbirth. Okay. Then we have the work of Yu et al. In 2020, where they look at obesity and social vulnerability. Okay, they look at the association between social vulnerability and obesity in the United States. They use a behavioral risk factor surveillance system, the survey that was carried out, and they compare that to county level SVI. So they observed that some components of the SVI were associated with obesity, And areas with greater social vulnerability index are those with older adults and special needs, people who require special needs. And those places have positive relationship with obesity. So this is telling that where we have high social vulnerability, we may also see an association of that with obesity. This was also corroborated by other researchers, Paretta in 2011 and Andrew and Keefe in 2014. So social vulnerability has important independent influence on older adult health, and the association may be complex, but we can tease out, their work tease out some of the factors within social vulnerability that could influence obesity. Next slide. Ramirez and Lee in 2020, they look at the El Nino effect on infectious disease and how SVI intersect with that. So they analyzed the 2014-2016 El Nino effects. They collected data about infectious disease such as diarrhea disease, malaria, dengue, chikungunya, Zika, and so on. And they consider also the environmental factors like the climate and the oceanic data. And they develop a social vulnerability index that they're going to use for the comparison. Next slide, please. So they found out that ecosystemic risk, in this case, they added the environmental condition and the social vulnerability condition. They added it together. They found out that when these two combine, when they are high, there is deprivation, the risk of infection is high when there is a higher level of deprivation, especially in terms of income and infrastructure. Let me take that again and carefully this time. What their study found out is that in terms of infectious diseases, there's a higher risk of spread and occurrence of these infectious diseases in places that has a higher level of deprivation of income and infrastructure. So which means already the entire country is under the El Nino effect. The El Nino effect brings about higher rate of infectious diseases. They now found out that places where this risk is even heightened are places where there is deprivation in terms of income and in terms of infrastructure. These are some of the components of their own SVI, of the SVI they constructed. So in a nutshell, what they are saying is that there is an intersection that when the biophysical factors, when they strike in terms of the El Nino effect, the socially vulnerable, especially those who are deprived of income and necessary infrastructure, they are unusually disadvantaged. So SVI revealed where those places are and what we can take it from there to now intervene. So this brings us to the last segment of the presentation where we talk about the limitations and future direction. So let me first of all talk about the limits. One of the challenges of many of the SVI we have right now is that it's rely heavily on census data. And most of the time, census maybe 10 years ago, 5 years ago, and so on. And things would have moved on. So we may be basing our index development on outdated data. So this is something that we need to think about. Then there's also the potential for ecological fallacy, which we aggregate. When you aggregate, the interpretation changes. If you aggregate data from community level to local government level to state level, the interpretation or the pattern will change. So this is something also that is a problem, a limit within SVI development. Also, using a single standardizing set for index for all hazard may be problematic because, for example, what will make you vulnerable, socially vulnerable to COVID-19 may not make you socially vulnerable to dengue may not make you especially vulnerable to other kind of hazard, to flood, for example. So we have to think about that when you are using a generalized SVI, there is limits to what it can do when you are looking at it for a particular hazard, a specific hazard. So we have to recognize that vulnerability is dynamic and is context specific. Then there is also this part of this assumption within SVI development that there is no interrelationship among the different factors, the 4 factors or 4 dimension or 6 dimension, whatever the number of dimensions we want to choose. There is the assumption that they are not, they are independent of one another. We know that that is not the case, but right now there are not a lot of work that has explored that interrelationship. I think that's a new direction that we need to follow, so that when we are developing it, we consider also the interdependence. So where do we need to go in terms of developing SVI? We need to start thinking of developing hazard-specific SVI, so that we can develop tools that are specific for certain condition, hazard, or certain disaster. Then we have to start considering the development of SVI by looking at new data sources like remote sensing data, social media data, and community level data. And this is one of the things we have done in Inform Africa. We're developing this new SVI using population-based data that are likely to give us more accurate reflection of what is going on and more timely data in terms of SVI. Next slide, please. Next slide. Francis, can you hear me? Okay. So there's also the need to start looking, back, please, back. There's also the need to do more research in terms of developing how do we weigh the factors, because we know that the current approach is that we weigh all the factors or all the themes, we weigh them equally, all the variables, we assume that they contribute equally to social vulnerability. But we know there is no society where all factors that confer vulnerability are all equal. Some are more important than the other, but right now, this is still an aspect that needs to be explored. And also the way we aggregate will also have to change with the understanding of how important the different factors are. And the next dimension I think we should be looking at is the integration of big data, the exploration of machine learning techniques in developing SVI. And at this point, I want to also invite everybody to subsequent training and webinar that we're going to have. The next set of webinar will look at how to develop it, and the last one will look at how you can use it with some of the tools we have developed. So I will look forward to seeing you all also joining us on that. Thank you very much. I want to acknowledge some of our sponsors and all the collaborators. Big thank you to every one of them. And Francis, over to you for questions. Thank you.
Thank you so much, Lawal, for the wonderful and interesting presentation. I'm sure the audience have learned a lot from this webinar. You gave us 3 segments. You introduced to us what the SVI is. You gave us some examples. You've also given us some applications as well. Yeah, you've also given us the dimensions or next areas to focus on, acknowledging the limitations and the way forward. I'm sure many of you have questions, so you can either put your question in the chat, or you can unmute yourself and ask the question. Lawal is on the call to answer your questions. Please feel free to post your question or unmute to ask your question. So while you think about your question, the slides will be made available The recording for the webinar will be made available. And I also believe the information about the next webinar and the next training will also be circulated widely. So please feel free to ask your question.
Yeah,
Yes.
yeah, thank you. This is Kazim on the line, please. Yeah.
All
Can
right,
you hear me?
Kazim.
So thank you, Prof, for
Yes.
that wonderful presentation. Thank you so much for that sunset and wonderful presentation. So my question goes thus, looking at DHS did some composite function in generating some of these, the wet quintile. So there are some variables that they put together to generate that, whether the person fall in the poorer region, the poorest region. So I just want to also confirm. So also calculating the SVI, is it the same approach, or is there a way in which this can be calculated? So, and then if peradventure it is so, what are the variables what variables, do we need to put into consideration when trying to generate this SVI? Thank you, sir.
Okay. Kazim,
Yes,
I think by the name, let me make an assumption that you're a Nigerian.
yes.
Okay. So wealth quintile is a different indicator altogether. Okay. Just like I mentioned earlier that social vulnerability index is much more robust from my experience in terms of telling us how vulnerable somebody is rather than looking at their wealth. Because wealth alone cannot give us a good picture or a robust picture of how vulnerable you are. So from my experience, SVI has outperformed wealth quintile because we have some examples, some tests and I think it's even in the literature that wealth quintile developed with the DHS example have not been very useful in terms of looking at vulnerability. Okay, it might be good to let us see where people are doing well economically, but we have to remember that social vulnerability captures more than just the economic well-being. Okay, it captures the demographics, the minority status, the language, and so on. So it's a more robust, that's the best way I can put it. It's a more robust index in capturing vulnerability compared to wealth quintile, which was not designed for capturing social vulnerability. So there are two different things. People may want to use wealth quintile for capturing vulnerability, but it will be something that is not appropriate. My judgment that I don't think it's appropriate for capturing social vulnerability. And as you have mentioned it now, I think I'm going to try and explore it and compare it to social vulnerability that we have developed in Nigeria and see how it performed in capturing vulnerability.
Yeah, thank you, sir, for that feedback. Thank you so much, sir.
You're welcome.
Okay, the floor is still open for questions. You can either put your questions in the chat or you will unmute to ask your question and it will be attended to. Any other question?
Okay, thank you, Prof. My name is Oyewole Idele. I think I posted some questions in the first phase of the presentation on the chat earlier. Listening to your response to Kazim, I'm just curious. I think there is one part of the question that has not been, maybe addressed regarding the computation of social vulnerable index.
Okay.
We all know that there are indicators that comes in. I think from your presentation, we have up to 10 different indicators, and it's different based on domains and context, as you have explained. I'm just curious, what are the list of these indicators that one should look out for? And I noticed in the limitation you stated that weighting, because I'm looking at a possibility of ranking. When you have a lot of indicators like that, there are more indicators that are relevant than the other. So how do you rank or weight in this situation? I know you mentioned weighting as a limitation. So I just want to know how you handle that. Then maybe to wrap that up with situation when you may say you are combining too much of indicators and you don't know which one is, your ranking is subjective. So how do you, avoid or
Resolve this. Okay.
resolve bias that may result from that? Yeah. Thank
Okay.
you.
Very, very good. You're right. I think I didn't cover one aspect of what Kazim asked in terms of the components. Now, one of the things that you should do whenever you're developing an index like this is the literature will provide you also a wealth of information on what has been found to influence vulnerability or social vulnerability in a particular area. I'll give you an example of what we used, the one we developed in 2015 and the one we are currently developing and the one we developed of COVID-19. We looked at what are the things that could increase or decrease or improve outcome or worsen the outcome. Let me give you an example. A place during COVID-19, the one we designed for COVID-19, we looked at number of healthcare facility within a local government. We look at the number of doctors that are available. We look at the number of nurses and other medical staff within each of these health care services medical facilities. Because we know if the number is high compared to the proportion of the people, the level of vulnerability of that community or that local government may be lower. Because if we look at the ratio, number of people and the number of health facilities that is available, number of people and the number of medical staff that could attend to them. We also looked at what is the proportion of people in those places are exposed to very poor air quality, because we know people who have pre-existing cardiovascular or breathing problem, things relating to their respiratory system already are more vulnerable to COVID-19. So we pick things that it's not possible for us to pick all. So once we have this compendium of variables, what we now do is to do a factor analysis, principal component analysis, to now narrow down what are the most important ones. So once we know the dimensions within these, then we can pick. If you have selected originally 50 from the factor analysis, you can narrow it down to the most important one, the ones that are loading highly into each of the factors that has been identified within this data set. So it's always good, go big and start narrowing down. That's the way, that's the method that we have designed and we have utilized on several occasions. That's also the approach by Cotter in 1996. That's the same approach from, but for CDC now, they have narrowed it down. They use the same set of variables over and over. But in our own environment, because of the consistency of data availability, we have to be more adaptive in looking at what do we have data for? What sort of variables do we have consistent data for? So we have to be more adaptive in our countries because of the challenge of data availability. So we start with a broad set and then we narrow it down to the most important ones, because there's no point picking a variable that does not contribute significantly to a particular dimension within your data, within the compendium of data you are looking at. So we take out those ones that are not important and we end up with a narrow list. Then, in terms of weighting, the general approach for everyone right now is that we give equal weight to all the variables when we're computing the SVI. But what I've done in recent times is to look at entropy approach to weighting the importance of each of the variable going into it. And what does that entail? What that entails is that if I have a variable that I've collected data for the 774 local governments in Nigeria, if that particular variable has a very high variation within it, which means the difference between the lowest value and the highest value is so high, then that variable has captured more information compared to another variable that the range, the difference between the highest value and the lowest value is so short, it's so narrow, then I should not give so much importance or so much weight to that particular variable because it's not capturing a lot of information. So that's one approach that I'm currently testing to see, because we have to be realistic. Within the real society, it is difficult for you to say, this is the most important. This one should carry a weight of out of 1, this should carry 0.5, this should carry 0.2, this should carry 0.3. It's really very difficult to capture that. But I'm not saying it's impossible, but it's still part of what I'm suggesting, that we have to start looking, how do we assign this weight? But one of the data-driven approach that I've used is the entropy approach. The more variable the data for a particular variable, the more variation there in terms of the difference between the highest and lowest, the more importance I should give to that, because in terms of information theory, that particular variable carries more information. So that's one approach that I'm currently testing, and I'm sure there will be other ideas in this respect.
Great.
Mr.
Thank you
Iwole,
so much.
I hope. Yeah, okay.
Yeah,
Thank you.
that actually addressed it. Thank you so much. And to
Welcome.
also answer the question about the DHS, the similar approach of complementary factor analysis and principal component analysis was actually adopted in using the composite score for the weight index that grouped it into 5 categories: the poorest, poorer, average, richer, and the richest. So, which is also similar to what you have explained. And I see here that even using the principal component analysis technique, like you have said, it also incorporating weighting indirectly, based on the factor loading. And
Yeah.
you have the rank of all your variables, like you say, in this case, up to 50. So that explains it, actually. Thank you.
Welcome.
All right. Any further questions? Okay, so we have a quick evaluation form for this webinar. So it will be put in the chat. So once you complete the feedback form, you will receive the presentation slides at the end of the feedback form. So once you complete it, you will get the feedback slide. So if there are no further questions, then I think we can end the webinar. Thanks, Lawal, for making time to share this with us. Like I said, the recording will be made available. The slides is already included in the feedback form, which the link has been put in the chat. So once the webinar goes live on the DS Africa YouTube channel, you will receive a notification. You could also subscribe to the DS Africa YouTube channel. As it's go there, you automatically get the notification. Thank you so much, and we will see you at the next webinar or training series. Thanks.
Thank you. Bye-bye.
Bye.